Hyponatremia is a very common problem occurring in around 5 to 10% of admitted patients. And I think it's very important for everybody to know hyponatremia. So this will discuss the etiopathogenesis, physiology, and another video I'll make on treatment of hyponatremia. So all those of you who know the answer to this question do not need to attend this webinar because you know the essence of sodium. So friends, 1 teaspoon, that is 5 grams, contains 85 milliequivalents of sodium. 1 gram of sodium, 1 gram of salt contains 17 milliequivalents of sodium. So 5 grams makes 85 milliequivalents of sodium. That becomes important when you're trying to kind of calculate oral salt and sodium intake. So this fellow, Sir Humphrey Davy, he was the one who discovered sodium many years ago, and he used poetry and theater to bring science to life. And this is a painting from the time when he was trying to introduce sodium concepts, and he was using poetry and theater to bring science to life. And I feel even today we should try and incorporate more poetry and theater to make science interesting. Now, this is a very fundamental slide, right? And you got to understand this. So if you look at the euvolemia, so that is in blue the water, and in blue is the sodium, and the entire thing is the water. So euvolemia, the blue is the sodium and the entire thing is the water. Now, in normal, you see it's almost the same as euvolemia. Okay, normal sodium you see, and you see the total fluid, extracellular fluid. And now in hypovolemia, what has happened? Sodium has decreased and water has also decreased. Okay, so if you see here, this is the sodium. So this was the normal sodium. The sodium has gone down, and this is the total water, and water is also decreased, but much less than sodium. So this is hypovolemic hyponatremia because the sodium decreases much more than water. Now, what is euvolemic? So euvolemic is typified by siadh, right? In this, sodium remains normal. You can see the sodium is normal, but there's a slight increase in water. All right, the total water slightly expands, and this is typically siadh is called euvolemic, but there is a slight expansion in the total water content. And this here is hypervolemic. So in hypervolemic, water has increased, sodium is also increased, right? Right? But this is not hyponatremia because the water increase is much more than the sodium. So it's a relative balance. How much sodium has increased and how much water has increased, or how much sodium has decreased, or how much water has decreased. So if you were to describe hyponatremia in one line, what is that one line? That there is relatively more water than sodium in the body as compared to normal. Okay. Now the combinations, permutations are there in front of you. So we'll start with the case, 18-year-old girl, no past history, repeated vomiting for 2 days, and she has a fever low grade. So BP is 110/85, pulse 120, GCS is normal, and sodium is low, potassium is low, pH is alkalotic, urea 65, creatine 61.1. Now question is, why is the sodium low? This is a very common scenario, and many of you know the answer to this because she has vomiting, right? She has vomiting. So will you send any test for seeing the cause? So here no real test is needed for seeing the cause. So okay, there's a battery of tests for hyponatremia. But if you look at the history and try to make out what is happening to the patient, 50%, in fact, more than 50% of the times, you don't need to send any tests. All right. And if you look at urea to creatinine, so this is a ratio more than 40. And in the lecture on urea creatinine, I told you about pre-renal azotemia. That is, when there is hypovolemia, the urea creatinine ratio goes more than 40. So here you see there is clear hypovolemia and according to urea creatinine, and there is vomiting which has led to hypovolemia. So this is hypovolemic hyponatremia. Now, if you look at the bottom, I have written why hyponatremia is not common in diarrhea despite GI losses. In vomiting, it is very common. So we shall see as we go on. In diarrhea, it's not common. It can happen, but it's not common. So this is a iconic slide approach to hyponatremia taken from the mother of all books for hyponatremia, that is Brennan Retter's kidney. So we shall explore this as we go on, and you can always refer to this. So this is a flow chart, and this is a classic flow chart: hypovolemia, euvolemia, hypervolemia. So whenever a patient comes to you try to fit him into one of these categories, and then you have urine sodium, which is the most important test, but you don't need to send it in all the cases. So if you look at hypovolemia, these are the causes and these are the extrarenal losses. These are renal losses. If you have euvolemia, then SIDH is very important, and you have the list of other causes, and hypervolemia, which is very evident. This hypervolemia, the patient will be having fluid excess, which will be generally evident clinically. So once you kind of fit the patient into hypovolemia, euvolemia, or hypervolemia, then you have to look at these causes. Does he have any of these causes? All right. And if it's not clear, then you send a urine sodium. Urine sodium is the most important test. All right. But generally, a good history and a good examination will reveal the cause of sodium. You don't have to send the battery of tests and increase the billing and lead to a lot of waiting also, because the tests take time to come. So we start with the pathophysiology of hyponatremia. The most important is antidiuretic hormone. So the antidiuretic hormone is secreted by the posterior pituitary, and it acts on the kidneys, and on the kidneys it leads to diuresis. That is, it leads to it leads to water absorption, free water absorption, and it concentrates the urine. Increased ADH will lead to increased water absorption in the distal tubules and collecting tubules, and lead to free water retention. And the other important hormone is aldosterone, which leads to sodium and water absorption. So antidiuretic hormone is the main hormone, and the stimuli for ADH secretion. The most important stimuli is serum osmolarity. Serum osmolarity of the body is maintained by antidiuretic hormone. All right. And it's very important to maintain serum osmolarity, otherwise all the cells will lyse. I shall explain that. And normal serum osmolarity is 280 to 295. So this is kept within this range by the antidiuretic hormone. What happens is, when the blood is flowing across the posterior pituitary, there are osmoreceptors in the brain here, in the posterior pituitary, and they sense the osmolarity. Okay, so the osmolarity is less than 280. Okay, then there's a decreased ADH secretion and free water excretion in the kidney. If the osmolarity is more than 295, that is hyperosmolar fluid or hyperosmolar plasma or blood, then ADH secretion is increased and there is retention of water. Now the second stimuli is effective arterial circulating volume. That is, if the effective arterial circulating volume decreases, all right, then this is an overriding signal. Even if the serum osmolarity is increased or decreased, this will be the overriding signal, because ADH will lead to retention of water and it will try to maintain the effective circulating volume. All right. If, for example, if it is already hypoosmolar, serum osmolarity, let's say 270, all right. So in this, the appropriate response will be to shut off ADH and to concentrate the urine and lead to diuresis. However, if the effective arterial circulating volume is low, okay, so the body has to maintain perfusion. So here ADH secretion will continue. In fact, it will be increased to retain water to maintain the effective arterial circulating volume. Now, the other hormone is aldosterone. Aldosterone role becomes important when there is decreased renal perfusion, again in conditions of decreased renal perfusion. So here, when there's decreased renal perfusion, renin, angiotensin, aldosterone system comes into play. There's increased aldosterone, and it leads to increased sodium and water absorption in the distal tubules. So there is increased sodium and water absorption. However, ultimately it is ADH which determines the total body water and serum sodium. Because the serum sodium depends on the total body water content, right? Because that is the osmolarity, and ADH determines the osmolarity. Now, what is the formula for serum sodium? Supposing you are asked how to calculate serum sodium, all right? So serum sodium is total body sodium plus total body potassium divided by total body water. That is the formula. Okay. So total body sodium is approximately, you know what it is, and total body potassium also. Potassium is intracellular and sodium is extracellular. And total body water can be calculated to some extent. You know, this cannot be perfect, but you can get an idea. However, though this is the formula, total body potassium is generally not considered, and we approximate this as serum sodium is proportional to total body sodium over total body water. So it is across all compartments. Sodium cannot get into intracellular space because it is pumped out by the sodium potassium pump, right? So what happens if the sodium is falling in the interstitial fluid, in the extracellular fluid? Okay, it is becoming hypoosmolar. Then water will move into the intercellular compartment because the osmolarity has to be maintained, the tonicity has to be maintained. That is why it's across all compartments, total body sodium by total body water, because sodium affects movement of water across all compartments. So again, in one line, what is hyponatremia? There is more water relative to sodium in the body. And absolute total body water and sodium vary from normal, whatever their proportion. So in a way, it's dilutional hyponatremia always, but they may not always be excess body water. So this is a slide here, which is trying to show you the concept of effective arterial circulating volume being the dominant factor even when osmolarity is low or high. So if you look at this is the euvolemic state and this is ADH secretion. So if you look at this level of 8, this is the 8 picogram per milliliter of ADH, and this is a normal osmolarity at something like 290, right? So at 290, this is the secretion of ADH. But if you follow this here at 270 also, you have a secretion which is similar. And here it is hypovolemic, right? And if you look at this here at a higher level in the hypovolemic state, even though it is hypoosmolar, the secretion of ADH is much more than the euvolemic state. So that just shows that effective arterial circulating volume is a dominant factor if there is a competition for ADH between the effective arterial circulating volume and the osmolarity. However, you know, this effective arterial circulating volume is not that common. It's mainly the osmolarity. The main role of ADH is to maintain the osmolarity of the serum, but you know, if there is hypovolemia or hypoperfusion or decreased intravascular volume, then that becomes a dominant factor. So apart from this, you know, what are the stimuli? So if you look at the stimuli, nausea, vomiting, pain, GA, drugs, malignancies, pulmonary, and CNS. So these are the stimuli for ADH. and it acts on V2 receptors in renal tubules through aquaporin water channels. So nausea, vomiting is very potent stimuli, and pain, general anesthesia. So in post-operative situations, you often get hyponatremia, especially if you give hypotonic fluids. Then drugs. Drugs are very important, especially those acting on the CNS, psychiatric drugs. Very important. And a very important drug is thiazides in the elderly. So the commonest cause of hyponatremia coming to the ICU, serious hyponatremia, has been thiazides in my experience, in my ICUs at least. The elderly ladies will come and they'll be confused and all that. You do the sodium, it'll be 100, 105, 110, whatever. And you have to take a detailed history because they will not know. And they'll be taking antihypertensives and it'll be thiazides. Right? We shall discuss this as we go on. So other is malignancies. So malignancies cause hyponatremia because they lead to secretion of ADH. And pulmonary causes of all kinds because hypoxia and hypercapnia. Hypoxia and hypercapnia lead to ADH stimulation, and CNS because the disease is there, so that leads to increased ADH secretion. Drugs cause increased ADH secretion by acting on the brain, and sometimes they increase the sensitivity of ADH on the renal tubules. So this is just to show you a shot from a very famous film, Lawrence of Arabia, if somebody has recognized it. So this was by a very famous director, David Lean, and this is a great shot, and this is about ADH. They are surviving because of ADH, the importance of ADH. Now moving on to serum osmolarity. So we discussed that ADH has to maintain serum osmolarity, and this is what happens if serum osmolarity is not maintained. This is an isotonic solution. You put RBC. This is a hypotonic or a hyposmolar solution, and this is a hypertonic solution. So you can see what is happening, and this is osmolarity. So what is osmolarity? What is osmolality? What is tonicity? What is osmotic pressure? So osmolarity is osmoles per liter of plasma, right? And osmolality is osmoles per kilogram of plasma. For plasma, osmolarity and osmolality is the same by and large. And tonicity is the effective osmotic pressure that is exerted by the fluid. And tonicity is the real determinant of osmotic pressure. And in calculating the osmolarity, this is the formula. Glucose, urea, and sodium come into the picture, but urea is not effective osmole because it crosses the cell membrane very easily. Thereby, the tonicity is determined mainly by sodium and glucose, mainly sodium. And for hyperglycemia, we have to subtract 2 of sodium for every 100 milligram deciliter of blood sugar above 100. We shall see this as we go on. So that is about serum osmolarity, and that is why ADH is important, because the cells will lyse otherwise. Now, as far as hyponatremia is concerned, there's an entity called pseudohyponatremia. Here, the serum osmolarity is normal. It is a lab artifact caused by myeloma, hyperlipidemia, and extreme values of hyperlipidemia have to be there. The myeloma often causes, but with the current technology used in the labs, this is not common anymore. Though sometimes in myeloma you may get it. The other cause is hyperosmolar hyponatremia, seen with mannitol, or hyperglycemia, which is just discussed, and glycine irrigation. So hyperglycemia does not really cause clinically significant hyponatremia, but it comes into the picture because you have to calculate the values. And mannitol can lead to hyponatremia because initially it will draw water from the intracellular space to the extracellular space. But when it causes a diuresis, it eventually leads to hyponatremia. And glycine irrigation used in certain surgeries like TURP and all has kind of become obsolete now. This is also not really a cause, but sometimes it can occur. One should be aware. So if you look at hyponatremia, true hyponatremia, always hypoosmolar. that is the serum osmolarity will be less than 280. 280 to 295 is normal. Hyperosmolar is what I told you, and isoosmolar is pseudo-hyponatremia. So if you want the value, if you look at the lab test for hyponatremia, one of them is serum osmolarity. So what is the role of serum osmolarity in the lab test? To confirm true hyponatremia. So lab tests have to be understood. What are the lab tests for hyponatremia? Now moving on to more specifics, this is the flow chart for hypovolemic hyponatremia. So hypovolemia, total body water decreased, but total body sodium is decreased much more, like I showed you in the beginning. So here now, if you want to go into the specifics of doing urine sodium, renal, you have to send the urine sodium. And if the urine sodium is less than 20 and more than 20 is the cutoff earlier, now it is 30. Urine sodium more than 30 or less than 30. And the way to understand this is if there is hypovolemia, true hypovolemia, without renal losses, then there will be increased absorption of sodium and water, right? And that will lead to a decreased urine sodium. So those are extrarenal losses. As you can see here, all these are going to be characterized by decreased effective circulating volume or true hypovolemia. However, if there is a renal problem, you're going to lose sodium and water in the kidney, then urine sodium is going to be more than 30. But because you're losing in the kidney, your effective arterial circulating volume is going to be decreased. Urine, a very important test is urine sodium less than 20. So here, hypovolemic hyponatremia less than 30 actually. Again, I repeat, it's not less than 20. It has become less than 30. So one is this extrarenal losses. Second is conditions like CHF, CLD decompensated, nephrotic syndrome, where the arterial circulation is effectively decreased, though the patient is edematous, because the cardiac output is low or because there is a vasodilatation, the effective arterial circulating volume is decreased. So here again, it functions in the same way as hypovolemia, right? There's a decreased renal perfusion. So it is going to absorb more and more. And urine sodium will be less than 20 or rather 30. So this hypovolemic hyponatremia, true hypovolemic hyponatremia with extra renal losses and edematous conditions with decreased effective arterial circulating volume are the only causes which lead to urine sodium less than 30. Rest of the conditions will be more than 30. Simple. We shall come to urine sodium, all right? And I will not read out all the causes because the causes have to be gone through. The concepts are more important. And here, just to look at this, so renal tubular acidosis, sodium is not important. Osmotic diuresis again is not important. Diuretics, you know what is diuretics, and mineralocorticoid deficiency, that is aldosterone deficiency in isolation, is again not common. What is important here is cerebral salt wasting syndrome. We shall discuss this. So this is what I mentioned, urine sodium more than 30 or less than 30 is now taken rather than urine sodium less than 20. So in vomiting, what is the mechanism? What is the mechanism of hyponatremia in vomiting and what is the problem? So when you vomit out gastric or intestinal fluid, what is the sodium content of the fluid? To cause hyponatremia, there has to be a hypertonic solution that has to be vomited out, right? If you vomit out hypotonic fluid, you're going to get hyponatremia. But all body contents are hypotonic to serum plasma. That is the sodium concentration of the fluids in the body is always less than plasma. So you should get hyponatremia, but you don't get hyponatremia, you get hyponatremia. So here the answer is one, that there is increased ADH due to stimuli by vomiting. I told you what are the stimuli for ADH. Secondly, there is free water intake orally or IV. If you replace the fluids that are lost, which have sodium, right? The sodium content of gastric intestinal fluid is more than 100 milligrams per liter, but it is not more than 135 milligrams per liter. So if you give fluids which are less than 100 milligrams per liter of sodium, you're going to dilute and you're going to cause hyponatremia. And similarly, very important is if there is so much vomiting that the arterial circulation gets depleted and this decreased effective arterial circulation, then again you're going to get a lot of ADH, as I told you earlier, because ADH tries to maintain the intravascular space, effective arterial circulating volume. So that is why vomiting causes hyponatremia. And here also, if there is recent vomiting, ongoing vomiting, then bicarbonate urea will occur, which will wash out the sodium. And you may get sodium more than 20. So here again, there's a confusion, right? Things are not always that clear. But the concept should be known, and a lot of you will give exams. So in active vomiting, the sodium may be greater than 20 because there will be metabolic alkalosis. And when there's metabolic alkalosis, bicarbonate will be washed out in the urine and it carries sodium along with it. However, if the vomiting has occurred and 48 hours or so has passed, then there will be decreased effective circulating volume and the kidneys will be trying to absorb as much sodium and water as possible due to aldosterone. And here, the sodium will be less than 20. Okay? Now, why don't you get hyponatremia and diarrhea? So the most important reason here is that diarrhea is not a stimuli for ADH. Vomiting is a stimuli for ADH. However, if in diarrhea also you give 5% dextrose and you do not manage it properly with fluids, you can get hyponatremia. Now, this is another case. This 60-year-old lady, COPD, hypertension, diabetes. She came to our ICU. She was on treatment with oral hypoglycemics, ACE inhibitors, and inhalers. She had a GCS of 6/15 and clinically euvolemic. Urine sodium was 45 and serum sodium 111. So, what is the cause here? What do you think is the cause? So I told you earlier, elderly ladies having hypertension always think of thiazides. It's very important. This lady was on thiazides. She was on ACE inhibitors, but ACE inhibitors are often combined with thiazides. So the answer here is thiazides. Now, what is the mechanism for thiazides-induced hyponatremia? So it is very interesting, and thiazides lead to sodium washout, all right, and there's a polydipsia due to thiazides. Thiazides per se cause polydipsia. By acting centrally, these patients tend to drink more water. And there's a diuretic-induced hypovolemia because it's a diuretic, intravascular volume depletes, and this leads to ADH stimulation. And also there's hypokalemia. So all these factors lead to thiazide-induced hyponatremia, which can be very severe. It can be very severe, and it's not that it occurs only when you start the treatment. If the patient is on thiazides, then certain precipitating factors can occur, right? A patient may decrease the salt intake, or there can be other issues, and they can get hyponatremia at any time. And the sodium can drop to 90 and 95, and seizures can occur, can be very severe. And because they are generally elderly ladies, often intubation is required. It can be quite bad. Now, moving on, this is another case from our ICU. So this is a polytrauma, traumatic brain injury, subarachnoid hemorrhage, amputation. Sodium again 122, urine sodium very high, 200, CP only 1. So what do you think is the cause here? So here the clue is the patient has traumatic brain injury, subarachnoid hemorrhage. And these patients have a condition called cerebral salt wasting. So cerebral salt wasting is a condition due to supposedly atrial natriuretic peptides, ANP, secreted by the brain. And here there's a washout of salt and water, gross washout of salt and water, what is called desalination. High volume of urine is poured out containing a lot of sodium, and they are hypovolemic. These patients are hypovolemic, and like I showed you in the initial chart, hypovolemia with renal salt and water losses. So this is a typical example. But CSW occurs mainly in neurosurgical patients. And in neurosurgical patients, you can have CSW or SIDH or combination of both. And CSW does not occur in neurology patients. It is very rare in neurology patients. It is a disease or a condition seen in neurosurgical patients. And here you will find the patient grossly hypovolemic. If you use focus, there will be clear evidence of hypovolemia. Treatment we shall discuss in the next lecture. So this is another case. This is a 60-year-old male, weight loss 3 months, pain abdomen, shortness of breath for 2 days, hypoxemic. He throws a seizure, intubation. We find the sodium to be 119, potassium 4, chest X-ray shows pneumonia. So what is the reason here? The answer is pneumonia. Pneumonia commonly causes hyponatremia because it causes hypoxemia. It can cause hypercapnia if predisposed. So the sodium is corrected, the pneumonia is corrected, and the patient goes home with the sodium of 137. Now he gets readmitted after a few days with chronic pain abdomen, and sodium is found to be 125. There is no clear reason, and a CT chest is normal, but abdomen CT is abnormal, showing a mass lesion in the stomach. So what is the answer here? Why does this patient have hyponatremia again? So the answer is he has SIDH secondary to a malignancy, which is a gastric CA. So sometimes the patients, not sometimes, or rather many times, the patients have dual etiology of hyponatremia, and here your urine sodium becomes a problem because it gets compounded by different etiologies. Now, we started the IV correction, and there was a rapid rise in sodium despite the precautions. As you see, it has gone up to 138, and after 3 days, patient is quadriparetic and responds with eye movements only. So what should you do now, and what has happened now? So as you may have guessed, he has developed osmotic demyelination, or what was previously called central pontine myelinosis. So we shall discuss this in the treatment section in the next video. Just a couple of words about this. So what happens is that when there is hyponatremia, there is dilution of the extracellular fluid with water. So here you can see on the left is a normal situation, while on the right is the hyponatremia. The red dots show you water, the yellow dots show you sodium. So if you look at the right picture, on the right of the blood vessel, there are much more water molecules, and the neuron has become swollen. And this is because there's water entry into the neurons. Like I told you, sodium cannot move across cell membranes, but the water has to move to maintain the equal osmotic pressure on both sides of the cell. Now, once this happens, the cell or the neuron adapts. It has to adapt. Otherwise, water will keep entering and there'll be a problem. And its cellular function also decreases. So once this neuron adapts, it takes around 48 hours or so. And if you correct it fast, then this adaptation is not able to lose the adaptation. You know, the neuron has adapted over 48 hours. Then it has to de-adapt. And it takes time. And if you correct it too fast, then again the neuron gets damaged. So if you see here, this is rapid correction of chronic hyponatremia. Anything more than 48 hours is chronic hyponatremia. And it leads to osmotic demyelination. in osmotic demyelination, the oligodendroglyocytes get damaged first. They are the most vulnerable. And these oligodendroglyocytes are the ones responsible for laying the myelin sheath on the neurons. There is demyelination once they get damaged. And this is cerebral edema, and cerebral edema is seen in rapid onset of acute hyponatremia. When there is rapid onset of acute hyponatremia occurring in less than 48 hours, the extracellular space has more water, it enters the brain, and the brain does not have time to adapt, and the neurons swell, and the ICT rises, and there can be brain herniation. So, this is a medical emergency actually. Now, moving on to euvolemic hyponatremia. So, euvolemic hyponatremia, classically typified by SIDH. So, it is called euvolemic, but the overall fluid in the body is slightly more than normal, and sodium is normal. So, why it is called SIDH and what it stands for? Syndrome of inappropriate antidiuretic hormone. And why inappropriate? Because once you get hyponatremia, the ADH secretion should be decreased. That is the normal response. However, here the ADH levels are increased. So the response is inappropriate to hyponatremia. Any patient with hyponatremia, the ADH levels should go down compared to baseline. But in these patients of SIDH, the ADH levels are higher than normal. Now, this can be because of various factors, and the etiology here is CNS disease, pulmonary disease, drugs, and cancer. So, CNS disease of all kinds, pulmonary disease of all kinds, many drugs, especially cancer drugs, but more importantly, the brain drugs, antidepressants, antipsychiatric, and all those, and cancer drugs, like I told you. So, what are the features of SIDH? So, this is persistent stimulation to secrete ADH by the stimuli, which is causing antidiuretic hormone secretion. There's free water retention due to increased ADH. There's decreased serum sodium concentration and osmolarity. And urine sodium is more than around 30-40, and urine osmolarity is greater than 400 generally. Because there is a water absorption, right, from the renal tubules. ADH is getting secreted. So the urine is getting concentrated. So the urine sodium goes up, the urine osmolarity goes up. Normal urine osmolarity is around this much only. So if the urine is getting concentrated, it has to be more than normal. That is the explanation for the urine sodium and the urine osmolarity. Now, assessment of volume status is very important. Assessment of volume status is very important. So, like I told you, it's called euvolemic. So the total body water is increased. Total sodium is normal. And urine sodium is greater than 30. And SIDH is a very important cause here. Sorry, that was supposed to be SIDH in yellow. But these are all the other causes. These are the other causes, including Addison's, hypothyroidism. That is why you have to send serum cortisol and thyroid function test in patients with unexplained hyponatremia. Don't send it arbitrarily. Okay, use some clinical acumen, clinical judgment to send these tests. A patient who does not have symptoms of hypothyroidism or Addison's disease is not going to have hyponatremia. Or if you're not getting any cause before sending these tests, then you can send these tests. All the different common causes I showed to you, because 95% of the times it's one of those causes, not this, what I showed in the massive flow chart in the beginning. So SIDH I talked to you, drugs I talked to you, then exercise associated hyponatremia again, it's a very rare cause, but primary polydipsia and low solute intake. So low solute intake is seen in beer drinkers. Okay, again, this is not common, but people who drink a lot of beer, right, and they don't consume too much food, alcoholics classically have this condition because beer is essentially water, right, and they get diluted. But primary polydipsia, yes, it occurs sometimes. And primary polydipsia and low solute intake are the conditions where you get less than 100 of urine osmolarity. That is the role of urine osmolarity. Urine osmolarity less than 100 is seen in primary polydipsia and low solute intake, that is beer drinkers. Now, what is primary polydipsia? Primary polydipsia is seen in those patients who are drinkers of a lot of water. They drink habitually or because of certain conditions a lot of water. So the entire system gets diluted with water and they pour out very dilute urine. And the serum and the plasma gets diluted, the sodium falls, and even the urine osmolarity is very low. 100 is very low. The lowest urine osmolarity is 50, and they have less than 100. Can't get lower than that. Now, hyponatremia in hypothyroidism and Addison's, why does it occur? So, in hypothyroidism, there's a low cardiac output because the metabolism is low, the requirements of oxygen is low. So, there's a low cardiac output, which again behaves like decreased effective arterial circulating volume. So, there's increased ADH secretion, and also because fluid is absorbed by the mixed emeritous tissue. So again, there's decreased effective circulating volume and increased ADH secretion. What happens in Addison's or adrenal insufficiency? There's decreased mineralocorticoid activity in the form of decreased aldosterone activity, which leads to increased sodium water loss. And there is increased glucocorticoid, there's decreased glucocorticoid inhibition of ADH. Glucocorticoid inhibit the secretion of ADH, and because glucocorticoids are decreased, ADH inhibition is lost. So there's increased ADH, increased water retention. So this is also important, hypothyroidism and Addison's, but it is not common unless the patient is having some other symptoms. He will always have some other symptoms. Or if there are no overt symptoms of hypothyroidism and Addison's, then this hyponatremia will be minimal, but it can occur, it does occur. Now, the question is my patient hypovolemic? I told you about SIDH, right? SIDH is a slight expansion of the total fluid status. And there is hypovolemic hyponatremia. So, hypovolemic hyponatremia and euvolemic hyponatremia have to be differentiated. So, one is clinical examination and clinical history. Fluid losses are there or not there, whether there's a condition which predisposes to SIDH and all those things. But often it's not so easy. All right. So hypovolemia has to be made out. So first is you have to take the history of fluid losses. History of fluid losses and any history which predisposes to SIDH or hypothyroidism or one of the causes I showed to you for euvolemic hyponatremia. Then you look at the examination, examine the patient. Is he dehydrated? What do you look for in dehydration? You look at the blood pressure. Is there a low pulse pressure? Is there a tachycardia? So these are two very important things. And you look for causes for conditions which cause euvolemic hyponatremia. Then you look for renal labs. Renal labs, I told you, blood urea to creatinine ratio more than 40, especially in younger patients, will indicate decreased renal perfusion and hypovolemia. Then you can use your history taking in drugs also, because a lot of drugs are used by patients. As you grow older, the list grows longer and longer. And if the patient on psychiatric drugs or thiazides, very likely that is the cause of hyponatremia. Then POCUS, of course, then comes into the picture. If nothing is clear, look at the IVC, look at the echo, and try to see what you can make out. So hypovolemia has to be made out clinically, whether there is any fluid loss, examination, what is the blood pressure, what is the heart rate, any tachycardia, and skin turgor and all those things don't help, and dry mucosal membranes, those things are things of the past now, right? And renal labs and focus. And here again, now urine sodium comes into the picture. Like I told you, I've showed you, you can review this again. I'm not going to repeat that. Now, psychiatric patient, I've told you, they are prone to polydipsias. And they also take psychiatric drugs. Polydipsia, again, they drink a lot of water. Why? Because they're psychiatric patients. And secondly, psychiatric drugs have anticholinergic effects, and these anticholinergic effects lead to thirst. And again, in psychiatric patients, the drugs that they take can cause siadh. The psychiatric patient is prone to hyponatremia, and if they are polydipsia, urine osmolarity will be less than 100. This is to show you beer drinkers, hyponatremia, where again urine osmolarity will be less than 100. Now we have this situation of pancreatitis, peritonitis, burns, etc. And in this, does capillary leak lead to hyponatremia? So it is not uncommon to see hyponatremia and pancreatitis, peritonitis, burns, etc. because the fluid that leaks out, so that is not having the same sodium content in most of the situations as the plasma. The sodium content is somewhat less. But because of associated factors, for example, in pancreatitis, there is pain, there is nausea, vomiting, which leads to ADH stimulation. Then in burns, there is again siadh because of burns stimulates ADH secretion. In the burns exudate, there's a lot of sodium loss. There's a lot of mass fluid shifts, which can lead to administration of fluids which are hypertonic. So all these conditions, can lead to hyponatremia. But in septic shock, do you get hyponatremia? Because septic shock is also a capillary leak syndrome. But in septic shock, you usually do not get hyponatremia because one, the fluid shifts are not so much. Second, it does not lead to siadh. And third, it is managed very carefully with isotonic fluids. Nobody gives 5% dextrose in septic shock. So in septic shock, we do not really get hyponatremia. Now moving on towards the end, we have this condition of hypervolemic hyponatremia, which is by far the easiest, but by far the most difficult to manage. So in CHF ascites, why do you get hyponatremia? Why do you get hyponatremia? So answer is simple, dilutional. But what beyond dilutional? What really is happening? So if you look at this flow chart, and if there's decreased effective circulating volume due to decreased cardiac output, one. Second, that leads to decreased renal perfusion. That is sensed in the macular densa in the kidney, and there is increased aldosterone, which leads to increased sodium retention and water retention. Now, this leads to secondary water retention, and also because there is decreased effective arterial circulating volume, there is increased antidiuretic hormone secretion. So all this leads to free water retention and hyponatremia, and all this condition will lead to a urine sodium of less than 30 because there is intense absorption of sodium and water. Now, AKI, CKD, again, hypervolemic hyponatremia. So why do you get here? Why don't you get hypernatremia, right? Why don't you get hypernatremia? Why you get hyponatremia? The kidney can lose more water than sodium, right? It is a failing kidney. So you can get hyponatremia, but you get hyponatremia. So it doesn't work like that. When the kidney is failing, it tends to retain more water than sodium. It loses sodium more than it loses water. So water is retained and you get hyponatremia, which is dilutional again. And in AKI, that is another reason. That is, there's a washout because there's a solute overload. So when AKI resolving phase of AKI, there is a washout of solutes, which leads to washout of sodium along with it. Apart from the fact that more water is retained than sodium when you have active acute kidney injury. Other causes are salt wasting nephropathies. There are conditions with the tubular dysfunction, CKD conditions, salt is lost, and nephrotic syndrome, which I've already mentioned. Please ensure when you dialyze that rapid changes in sodium do not occur in these patients. So that is hypervolemia. Total body water is increased much more than total sodium, and urine sodium 30 is taken now. Acute or chronic renal failure more than 30, and if it's less than 30, nephrotic syndrome, cirrhosis, cardiac failure. And now, lastly, which test should we use in hyponatremia? So serum osmolarity, urine sodium, urine osmolarity, and rarely uric acid, thyroid function test, cortisol. So I explained all these tests to you, and you can go through the video and you can understand again why I have mentioned these tests, why these tests are done. Actually, you need only urine sodium. Like I explained throughout this video, if you have followed the video, if you have followed the lecture, you will understand this, right? Sometimes you need thyroid function test, sometimes you need cortisol. What is the role of uric acid? So uric acid helps in distinguishing hypovolemic from SIDH or euvolemic hyponatremia, because in hypovolemic hyponatremia, uric acid is more than 4 milligram per deciliter, while in SIDH it is less than 4, because increased ADH secretion leads to uric acid washout in the urine. So that helps to distinguish between hypovolemic and SIDH, which is classified as euvolemic. So urine osmolarity only in two tests, two conditions. One is primary polydipsia, second is beer drinkers. Urine sodium more than 30, less than 30 is the proper list. It will be less than 30 in only those conditions where there's decreased effective arterial circulating volume, because there'll be increased sodium and water absorption, and serum osmolarity less than 280 to determine true hypoosmolar hyponatremia. So moving on to this condition, interpretation of urine sodium. So now finally, interpretation of urine sodium. I've tried to put it down for you. Urine sodium less than 20-30, hypovolemic hyponatremia without renal losses of salt and water, or decreased effective circulating volume, CHF ascites, active vomiting, third spacing, and urine sodium greater than 30, SIDH, CSW, renal losses. Very important, again, I repeat, is a dual etiology. Many patients in the ICU have dual etiology. For example, patient can have pneumonia and CHF, right? He can have a cancer and he can be on diuretics. So many times, dual etiology is very common. So here your urine sodium will not help. It will be very difficult to interpret. So you have to use clinical sense and you have to understand sodium. And understanding hyponatremia is not easy. It is a very difficult topic. It's a very conceptual topic. However, I have tried to make it easy. So whatever questions you have, please put forward. I'll be happy to answer. And also very important, this last thing here, send before starting saline. If you have to send urine sodium, you have to send it before starting saline or 3%. If you start the fluids, then your urine sodium changes. You give 200-300 ml of fluid, the urine sodium will change, because that is going to be poured out in the urine and your urine sodium will change. And that is a very big problem, because if the patient comes in the ER, they will start something. By the time he comes to the ICU, you're trying to assess, the game is over as far as urine sodium is concerned. Now, there's a condition called acute hyponatremia, which I referred to earlier. Hyponatremia can be acute or chronic. Once hyponatremia has gone beyond 48 hours, then it is called chronic. And chronic adaptation occurs, like I told you. However, acute hyponatremia is prone to cerebral edema, raised ICT, herniation, and death. All right. And these are the causes of acute hyponatremia. And you may ask me, you never told us the definition, you didn't tell the clinical features. So I'm sure you know this definition. Anything less than 135 milliequivalents per liter is hyponatremia. And clinical features of hyponatremia pertain to the CNS, anything from confusion to seizures to status epilepticus, and The other thing is sometimes it causes nausea and vomiting also. Just like vomiting and nausea can cause hyponatremia, rarely hyponatremia can cause nausea and vomiting because ICT rises, cerebral edema, so it can lead to sodium nausea and vomiting. And a very rare complication is neurogenic pulmonary edema. It can lead to neurogenic pulmonary edema also at times because again the effect on the brain, the ICT rises, and you can get neurogenic pulmonary edema. Very important is the absolute serum value is less important than how fast the sodium is dropping. The faster the sodium drop, the more serious and more severe the symptoms are going to be because there is less time to adapt. So if the sodium drops from 140 to let's say 130 in 24 hours, that is much more serious than someone who develops a sodium of 100 over a period of 7 days. Symptoms are directly related to the rapidity with which the sodium drops. And please be cautious in treating the sodium. We shall discuss the treatment in the next video. I shall put it up very soon. This is the approach to hyponatremia. Again, we come back. The circle is completed. I started with this. I'm back to this. You can go through this flow chart and try to understand it. Try to make a clinical diagnosis. Most of the times you'll be right. Okay. And urine sodium has to be sensed at times, and other causes are also there. But you have to be, smart enough to realize whether the patient needs a urine osmolarity. Is he a psychiatric patient? What drugs is he taking? Can he have Addison's? Can he have hypothyroidism? So it's quite a clinical challenge to diagnose hyponatremia, but 75 to 80% of the times the diagnosis is very clear. All right. And thank you for your patient hearing. And with that, I shall close the session. Please put up your comments, questions, whatever you like. I'll be happy to answer them. Thank you very much.